All right. Welcome, everyone. Thank you for joining us today. Our webinar is the future of workplace violence prevention, focusing on what's most important. And my name is Cassidy Avila. I'm the program coordinator for the Texas A&M Health Rural Engagement Program. And before we begin, I will let you know that we're recording this webinar. We will share a copy of the recording with you and a follow-up email from the Rural Engagement Program. And we would love to hear from you, your questions and comments from the presentation today, and any questions that you have. We will have time for Q&A following the presentation. So if you think of something that you want to comment on or a question that you have, please go ahead and either drop it in the chat or just make a note, and we will definitely have time for that following the presentation. It's now my pleasure to introduce our speaker, Brendan Riley. Mr. Riley is a seasoned leader in healthcare security and workplace violence prevention with over 2 decades of experience dedicated to ensuring safety in healthcare environments. Holding a Master of Science in Healthcare Management and Policy, he has a strong academic foundation paired with extensive practical expertise. Currently serving as the Director of Security, Parking, and Transportation at Lahey Hospital and Medical Center, he has presented at numerous national and international conferences, authored publications, and contributed to significant industry projects, including the International Association for Healthcare Security and Safety Workplace Violence Prevention certificate program. His career is marked by a deep commitment to advancing safety standards in healthcare, earning him numerous accolades over the years. Mr. Riley, we are honored to have you presenting on this critical and timely topic in healthcare, and it is all yours now. Thank you for joining us.
Thank you so much, Cassidy, for that introduction and warm welcome. It's really my pleasure to be with the group today, presenting on what's such a critically important topic for all of us in 2025 and beyond. Just a little bit more about the International Association for Healthcare Security and Safety's work. We have that 6-hour certificate course on workplace violence prevention and healthcare. And I'm pleased to announce that we just reached over 900 healthcare professionals who have completed that program, representing all 50 states across the country. That dives really deep into the details of program building and accreditation compliance and continuous program improvement and evaluation. That's not the purposes of our hour together today. This is just more my vantage point of a 25-year healthcare workplace violence prevention leader and public safety and security leader. So as we go forward into this program here, I really want to challenge everybody. I hope you reflect on 3 or 4 things that I talk about today with some new perspective. You don't have to agree with everything I say. I just want you to be really thoughtful about this and go back to your organization, determine what are your foundations for workplace violence prevention as we move forward here. I'm going to tell you what mine are and what my best recommendations are, but I hope that you go forward with a thoughtful perspective and you engage people in your workplace and ultimately impact meaningful change because our colleagues, our caregivers really deserve our best as leaders protecting them. So I always want to start here. I mean this with the whole of my heart. What you do is the most noble profession, taking care of the sick and the injured, those in crisis, those at the end of life, and their family members at what might be the most challenging and difficult moments of their lifetime. When we make connections with them, I can think of nothing more noble than that. Being a healthcare giver is an exceptional thing. And I think what makes us great is our core values. And these are kind of the core values that I see show up in our best caregivers over and over. And what my connection is with the rural healthcare community is not where I work. You know, I work at a tertiary academic medical center, a level 1 trauma center, part of a system of over 50,000 employees, and I'm city folk. I grew up in a city. However, I was asked by the IHSS to present at American Hospital Association's World Healthcare Leadership Conference in San Antonio, Texas, back in 2023. And I let them know I haven't worked for critical access hospital or this type of environment. But I had a few months to prepare, so I made connections with folks in the rural healthcare setting from all over the country. And that what a great experience that was for me. I learned an awful lot. And what I learned most of all is what you folks do is healthcare at its purest form. taking care of your neighbors, people you see on the Little League field or in the grocery store. And you do so in the manner that is so under-resourced. Even in my medical center, oftentimes we feel really challenged financially and with resources and time and people. But you get by with the bare minimum. And if you make a bad decision or a mistake, you might have to shutter the doors of your facility. So I tip my cap to what you folks do. I am, really honored to share my vantage point with you, and it's been certainly one of the honors of my career to get more familiar with the folks that provide care in the rural setting. So here's my hypothesis. I think the overwhelming majority of healthcare workplace violence-related injuries that are physical in nature are entirely preventable. I'm the person at our root cause analysis meeting that always votes for this violence was entirely preventable. And I think as my remarks move forward, you'll see why I've developed that vantage point. But the only way we can get there towards prevention and mitigation is if we're really thoughtful and strategic in our process. So for me, for starters, I always like to review my vantage point on the current state of things. I think we can all agree, and I'm not going to overwhelm you with data today, but this is from the IHS Foundation Annual Crime Survey relative to simple assaults and injuries. And the way that they do this is it doesn't matter if you're a 1,000-bed hospital or a 10-bed hospital. As you put into this survey, it's all put into an aggregate and measured across the rate per 100 hospital beds in the aggregate. And the last reported year was 2022. We saw an all-time high in simple assaults towards caregivers per 100 hospital beds, 22 incidents reported. Typology, type 1 is violent intent, stranger type violence. Type 2 is patient or visitor generated. Type 3 is lateral violence, worker to worker, and type 4 is outside relationship violence. You can see on that pie that 93% of the reported in violence was patient generated violence. So we have to plan and prepare for all types of violence in our workplace. But that data tells me that we have to put the majority of our focus and our time and energy and resources to preparing to prevent and respond to patient-generated violence occurring at the bedside, often reactionary in nature. That's not necessarily what most organizations do. And what we see year over year is a steady increase in the volume and severity of violence. And we've been seeing this for quite a period of time now. Violence in healthcare was an epidemic before COVID-19, but the pandemic has certainly exacerbated it, and we're still feeling the really impact of the pandemic on violence. I love healthcare in that I think that data really drives all of our decision making, but not necessarily when it comes to workplace violence prevention from my perspective, and I'll share with you why. We're decades into trying to do something about violence in healthcare, but I do believe we're ruling out the same interventions over and over again. I love the old quote attributed to Einstein that the definition of sanity is doing the same thing over and over again yet expecting different results. And I think that might, really have a part here in workplace violence that we do so unconsciously. The current state of things, I really see, as I mentioned earlier, we see people at their absolute worst, at their breaking point. And the root of all conflict, folks, is actually just two things: bad past experiences and unmet expectations. I think all of us have probably had a bad healthcare experience, either with us as the patient or one of our loved ones, which is often even worse. And we know what our patients' expectations are in 2025 and beyond. They expect their care to be delivered immediately. They expect that the quality of that care to be perfect, and they expect it to be free. And none of us can deliver perfect, free, and now. So, for systemic reasons outside of our control, we're often going to be engaged with people who have unmet expectations, which really breeds conflict and what I call emotional confrontations. I think we need to be hyper aware of this concept that I refer to as patient burnout. I think we're all well aware of caregiver burnout, and we need to be. I think the suicide rates among physicians and nurses is staggering, and the impact of the stress of COVID times was so real for us that we know a lot about caregiver burnout. But patient burnout, to me, can be summarized as folks are paying more than they ever have before, what they perceive to be lower quality of care, in the very least, a much more difficult time accessing care than they ever have in the past. And we're seeing this nationally lead into some real serious resentment towards caregivers in hospitals that feels really new. Resentment towards healthcare is not new. It's been around for generations, but it's usually really been focused on the pharmaceutical industry and the health insurance payer industry. Now, for really the first time, we're feeling that same level of resentment consistently directed towards hospitals and caregivers. Historically, people have usually had an affinity for their doctor and the hospital they choose, but we're seeing that erode rapidly. We're seeing regular folks like us have this mindset that, geez, I wish I got the quality of service that my pet does at the veterinarian when our loved ones go to the hospital. It seems like there's constantly delays, lapses in communications, and it can be impossible to get an appointment or the care that we're trying to obtain. So this is just our reality. And I think when we try to analyze violence in healthcare, it starts by having a general understanding of this current state of things. And I'll elaborate that to no fault of our own, because we often do this very unconsciously, we tend to apply a reasonable person standard to the folks in our care, and often the results can be disastrous. Okay, believing that others will react as we would is the single most dangerous myth of intervention. That's one of my favorite quotes. It's from Gavin de Becker in the book The Gift of Fear. And when I read that quote, I highlighted it. It really spoke to me because I knew that I did it so often in my early career as a uniformed security professional, engaging with people who were emotionally confrontational. What I tended to do is I would project what I would do in that situation onto them, because what we can relate to most is our own experiences. So unconsciously, we tend to do that. We project, and it's onto people who might be aggressive by nature. I've learned that at least 20% of the population's primary means of communication is aggression, not the response to bad stuff that happens, their baseline way of how they communicate with other people. All right. And you bring them in the healthcare environment where we're not meeting their expectations, where they're having a bad experience. It's a recipe for explosive, agitated, aggressive behavior. And when we try to build these boundaries that expect these folks to behave like perfect ladies and gentlemen who are not reasonable people to begin with, and then they have the stressors of a healthcare experience, I think it sets us up for a no-win situation. At worst, I've certainly networked with some healthcare organizations where there was definitely an undertone of an adversarial culture, an us versus them. Caregivers in particular against the behavioral health patients, those in the throes of substance use disorder, chronic alcohol use, untreated mental illness. So, you know, without any type of intention, we tend to see this relationship damaging actions that we often take with the goal of safety being counterproductive. One is with the cell phone. I go around to a lot of hospitals that medical patients will use their cell phone with impunity and at all times. I tend to believe that this has become almost like an extension of the human body. It's that important to all people, including behavioral health patients. But so many places will take away the phone from a behavioral health patient as just part of their standard operating procedure, including a cooperative behavioral health patient. And I've lost count of how many incidents I've reviewed where an otherwise cooperative behavioral health patient starts throwing punches and fighting the caregivers as they try to forcibly take the cell phone away from them. which is a right that's given to the medical patients right across the hallway. So to me, I take a step back and I look at that and I see it as relationship damaging. And of course, if somebody's coming in, particularly in an emergency department, and they're floridly psychotic, take the phone always. All right. But if that person is cooperative, there's there a pathway to creating what I call a one chance policy to retain your phone. Of course, you have to take the cover off. It could be stowing a razor blade or drug contraband in the cell phone case and make sure it's inspected for safety, but give that patient that one opportunity to use it appropriately. Maybe you give them a written agreement, which I advocate for, that says you have one chance to use this appropriately if you start audio and video recording staff members, if you start live streaming, if you start yelling and screaming at somebody on the phone, we take the phone and you don't get it back until your time of discharge or transfer. But that's very relationship building. I've seen a lot of patients cooperate with this being the bargaining chip. Now they are disrobing out of the street clothes and putting on safe hospital clothes. They're providing urine specimen. They're agreeing to take medication cooperatively with the bargaining chip being retaining the phone. But more organizations than not are still taking the phone by any means necessary, and it's leading to unnecessary patient restraints and brutal assaults and injuries on caregivers to try to remove that phone from an otherwise cooperative patient. I think we need to take a step back and re-examine that. And ultimately, the words that we often use can be very relationship damaging. The term frequent flyer is prevalent in healthcare, but that's slapping a label on people. I prefer a patient that's known to us. I once had a patient sitter refer to the patient that they were observing as a frequent flyer when engaged in conversation with another colleague. And that patient got out of bed, walked over, grabbed her out of the chair, picked her up, and threw her across the crowded hospital, and she landed on her head, incurred a very serious injury. And she did not deserve for that to happen to her as a caregiver, but we ought to learn something from it. So sometimes we have very relationship damaging actions towards our patients that might push them further down a pathway to violence. After the fact, the patient said that was what triggered them to react with physical violence. So I'm one that advocates for seeing some of the commonplace patient behaviors that we see is a symptom of illness. Agitation to me is a symptom of untreated mental illness. We don't get mad at the respiratory illness that starts coughing in our hospital. We see that as symptomatic of their medical condition. So sometimes untreated mental illness is going to lead to agitation. How do we navigate that here? And also, do we have an awareness of the impact on trauma on people? I love the fact that there's more and more emphasis nowadays on trauma-informed care for our caregivers of how to effectively communicate in these moments with folks that we know are going to be seen while they're in crisis. This is something, a concept that we have to all stand united on. When I travel, I hear far too often these days that violence is just part of the job, that it's what we signed up for. We have to stand united against that. None of you signed up for combat by showing up to a civilian hospital to be a caregiver. Okay. But the reality is, violence is epidemic. It's on the rise. It's so prevalent that even though it's not part of the job, we need to understand that it's happening at an alarming rate, and we need to start coming up with measures of what we can do about it. And it's global epidemic. That image is actually from Australia in a public service campaign they rolled out there to protect their caregivers. So it's never okay. We need to stand united about it. But what's the solution? Ultimately, over the course of this presentation, I'll make the point that it's us. There is no other solution to preventing violence and ending violence than all of us as caregivers. Um, is disrespect part of the job? This is my favorite question to ask colleagues who work in my organization. I speak at nursing orientation every other week. And there's certainly no right or wrong answer, and the responses tend to vary. But the favorite response I always hear folks holler out is it shouldn't be. And I agree wholeheartedly. I mean it when I say it. What you folks do is the most noble profession. Of course, you deserve to be treated with the utmost respect at all times by everybody in your care. Um, However, the question is not should, the question is is. And I always ask caregivers that, who's ever shown up as your best self, where your core values just reflect through you, and the person in your care still disrespects you in those moments. And the feedback I always get is that happens all the time to people. So to me, that answers the question. It shouldn't be, but our reality is we see people at their worst. We see them when they have unmet expectations. We see them when their emotional brain takes hold of the moments that we're encountering them. I like to think thinking brain, emotional brain. Thinking brain shuts off like a light switch. Emotional brain, lizard brain has the driver's seat. So often during these encounters, we become the lightning rod for this disrespectful, aggressive behavior to no fault of our own. It could be a blank face standing in front of them in those moments, but the way they're feeling emotionally, they will target us. So to me, that answers this question as part of our reality. Violence, no, we draw the line there, but disrespect, I'm alarmed when people, create that perception that we will be always respected by everybody in our care. And the best example I can bring up is all of these really customer service oriented fields. And so often, prior to entering healthcare, so many of us have worked in some of these historically really customer service oriented fields. We're all human services workers. I'm not suggesting we're apples to apples, but we're all human services workers. I came up working at the large retail grocery store since I was a teenager. And I learned more about conflict management and resolution in that grocery store than I ever have in any hospital. And any of us that have past experience at retail point of checkout, hospitality, bars, restaurants, grocery stores, you understand your manager told you what rule number one was. And even if the customer was wrong, we always defaulted back to rule number one. Okay. And I'll share with you when I worked in the grocery store, probably 98% of the time we were right, but 100% of the time we defaulted back to this rule. Typically, these fields do two things exceptionally well. Service recovery, the really agitated person with a bad experience, here's 25% off next time, the tension comes down. And they're really good about making a referral to the manager or the person in charge. That is a great tactic. We should do that more in healthcare. My early career, I wore a uniform. I was a security professional. I was the daily lightning rod for disrespectful behavior. But the past 20 years, I show up to work like this in a leadership role. So now it's my people in uniform who are that daily lightning rod for disrespectful behavior. But one of their tactics is so they can call me. And every time they do, that person who's yelling, screaming, and swearing in their face, as soon as I walk into the room, totally changes their behavior. Now they're a perfect lady and gentleman because they're interacting with a perceived person in charge. For nurses, it's often that white lab coat effect when the doctor walks into the room and that patient or family member who was terribly disrespectful and nasty is now polite and positive. All right, to me, it's whatever's going to bring that tension down in those critical moments. Candidly, in healthcare, sometimes whether we realize it or we like it or not, we do the inverse of this. It's our patients and their family members that are always wrong. Okay. And often, if we go into an encounter with that mindset, the results can be disastrous. It's like pouring gasoline on flames. Okay. So I think strategically going into these encounters, trying to let these folks be heard, understanding it's okay to say we screwed up, how can we make this right? Really can de-escalate a situation from becoming worse. If you don't remember anything else I say, please remember this. Um, the key to workplace violence prevention and de-escalation is focusing on their grievance first. Put their bad behavior off to the side for a moment. Focus on their grievance first supportively. Very often, organically, that will bring the tension down and enable us to do the important work of revisiting that bad behavior and resetting expectations for moving forward. Very often in healthcare, whether we realize it or not, we do the opposite. we put their grievance off to the side and we fixate on the bad behavior. And very often that will push people further down that pathway of being more agitated and aggressive, up to including physical violence. So, one great campaign I've been doing for years is focus on the grievance first. Then, when the time is right, reset behavioral expectations and focus forward. So, the real point of this presentation is realizing that everything relative to workplace violence prevention is important, but there's certainly some things that are more important than others. And how do we determine it? At some level, whatever we do in healthcare, we're all risk managers at some level. So when there's so much on our plate to consider, especially at under-resourced organizations like you work in, you know, we really have to choose, do we want to focus most of our energy on what might happen or what is happening? Okay, so to me, understanding what are the violence-related events that are occurring with frequency here and starting there as we try to develop our comprehensive plans the best we can. But it's really about measuring the probability and the level of harm. And then when we've determined that initial risk level, what can we do to mitigate the probability and the severity of harm? What actions can we take that can really try to reduce that risk level? So that's really going to be the foundational point here. So to me, from my vantage point, these are the current priorities in healthcare relative to workplace violence and have been for several years. Um, I'm not dismissing these things, but none of these things are on my top 10 list of what's most important. Here, from where I sit, are the most important things to try to prevent and mitigate violence in 2025 and as we move forward. And I'll talk a little bit more about them. Very often, it's helpful to start here by discussing what I think are elements of a program. They are important, but they are not what's most important, what I call foundations. To me, any low probability event is an element of your program. In the lowest probability events in a healthcare setting are active shooters and weapons related violence. But think for a moment how much time and energy is invested into preparing and training for that. I'm not minimizing it. Our colleagues want this training. They're concerned about this from what they see in the media. But there's also been a backlash. So many caregivers I've networked with that have been through these full-scale drill exercises or these dynamic simulation rooms with simulated gunfire as they've not had any type of introductory training. They're just thrown in full speed into these type of exercises. That's the common theme. I felt more traumatized than trained. There's been organizations that have been sued. There's been caregivers that end up out of work on leave for emotional trauma for 3 months. So unintended consequences, but I think we need to be more thoughtful than that. I will never be a proponent for a dynamic simulation room for active shooter training or a full-scale exercise. There's always going to be people that don't get the message that it's just a drill and the risk that that inherently brings to everyone involved. And also there's just, that likelihood that people go through this exercise and it might give them a false sense of confidence when it comes to fighting skills. And usually within the next 2 weeks or so, they're going to forget everything they learned in the training. So what I am an advocate for anything that's low probability is awareness and at most department level training. And that's what I've done with my organizations for many years, where we start with the same hour of training that everybody in the workforce gets relative to extreme violence and active shooter situations. Here are some of the key concepts that we go over at the top of the screen. But we've also partnered with our local region for emergency preparedness, and we do what I call 10-minute drills, which is bringing the run, hide, fight principles to the department level where people actually work. So that expands upon just the general awareness training to doing a tabletop, if you will, in the environment where they directly work. And it's been really well received. And I feel as though we're making the best effort we can to empower our workforce with some training and some options, but also realizing that these are extreme outlier situations and incredibly low probability events. By the FBI data, for a 20-year stretch, there were 4 active shooter incidents in healthcare over 20 years. So that is such a low probability event. That's why I think that this is appropriate. Weapons detection has really been a major emphasis. A lot of organizations have invested heavily into weapons detection systems. For it to be effective, it really has to be like what we experience for those who fly with the airlines, what we see with TSA and airport weapons screening is really what it takes, equipment and personnel wise, to actually do this effectively. It's certainly not my security colleague on the left-hand side of our screen here using a wand up close and personal with someone that might be an armed threat, performing that responsibility on their own with less than reliable equipment. However, this is certainly front of mind. People at the CEO level, oftentimes any materials they're getting about workplace violence prevention are going to be really heavily focused on weapons detection and other systems. Again, we're protecting against really low probability events here. I'm not a total proponent to weapons detection, but I think all organizations need to be thoughtful if they make this investment. It really starts by having a robust visitor management program and access control technology. So if you're controlling who's coming into your facility, if you have access control on doors that secure them, they require a badge, swipe, and accountability of who's entering these areas, then the next logical layer to add on would be weapons detection. But so many organizations I network with, they do not have robust visitor management. They don't have a level of electronic access control on the doors that they should, but they're all in on weapons detection. So this equipment is very costly, and often folks underestimate what it takes to operationalize this equipment with people to do it safely and effectively. Like I said, it takes really the effort and the people that you see at the airport if you fly on the airlines. Here, and if you're going to do it, I always advise any organization to do it at all entry points and to make sure you screen your workforce. Your workforce is actually the most likely to bring a firearm into the healthcare workplace. But very often, folks just do it for 12 hours a day at an emergency entrance only. And there's so many other viable entry points in the facility that a bad actor would go if they were trying to come into the facility to do harm. But a lot of thoughtless from, I hate to be so judgmental, but a lot of thoughtless practice is happening out there, just with the goal of getting better results on their employee engagement surveys relative to culture of safety. But perception of safety to me is far different than actual safety. If folks are going to do this, I think they just need to realize, to partner with the right vendor who's going to be honest up front about what it takes to operationalize this equipment and some of the limitations with the equipment. Another major area of focus is specialized detections in emergency departments and behavioral health areas. I can really support this. And it's interesting to me with the folks I network with how often they are uncovering firearms and especially edge weapons, knives, in these areas when these folks have already passed through a walk-through weapons detection system at the main entrance into the area before they get to the department. So I always find that interesting. But if you stand this up, you're going to encounter weapons for sure. So do you have a policy and procedure and a process? Are the people adequately protected that are performing the weapons detection? And that's not often the case. And again, what are we going to do when we encounter these sorts of weapons here? But it does make some logical sense to me. But when you look nationally, it's incredibly, low likelihood. It's extreme outliers when weapons encounters occur in hospitals. Don't get me wrong, I'm not minimizing the impact of a weapons tragedy and situation. It could bring your organization to its knees. However, our ability to mitigate that from occurring is pretty low, even with these systems in place. The much greater probability and often overlooked is improvised weapons. When people in our care take what's already in the environment of care and they weaponize it for self-harm or they weaponize it to assault colleagues. But often there's no training for our colleagues on how to navigate these type of attack situations with improvised weapons. But I do think we're being more and more thoughtful about removing anything from the environment of care that could be weaponized for self-harm or to assault caregivers. And if you're not doing that work, I encourage you to invest some time and energy of reviewing your environment of care for objects and items that could be removed, maybe checklists in certain episodes of care. We bring certain things out of the room, etc. But this is much greater probability than any of the deadly weapons types of attacks. We've seen a lot of healthcare careers ended from caregivers who were harmed by improvised weapons. And without question, the greatest probability is that bedside patient-generated reactionary violence that is assault with hands and feet. That's by far and away the greatest probability. And the overwhelming majority of caregivers who are seriously harmed and brutally battered on the job are attacked with hands and feet. Okay, so it's often right up close and personal at the bedside, often during medication administration, some sort of bedside episode of care, application of restraints is where we're really seeing that reactionary violence with caregivers who are totally unprepared to be at the bedside caring for somebody with active risk behaviors. Believe it or not, folks, this is an accurate statement. The average U.S. healthcare worker has far more training than active shooter response than they do bedside protection. So when you play the probabilities, that doesn't make any sense to me. I'm not minimizing the importance of training for extreme violence and active shooter. I always deliver that to our entire workforce, but we do an awful lot more training and time investment and resource investment to bedside protection and these encounters that occur with patients who might be escalating towards verbal and physical violence. Zero tolerance campaigns have been incredibly prevalent in healthcare for 20 years now. They're still very prevalent across the country. I was an early adopter of this in 2004 and went across my hospitals and posted those were the actual zero tolerance symbols that I used. And we had similar signs like this, these list of thou shall nots of behaviors that occur with frequency at most hospitals, and that we are powerless to have true zero tolerance over to prosecute people. The justice system is out of our control, and very often the people that carry out these sort of behaviors, they're not handcuffed behind the back and perp walked out of the hospital with law enforcement. Very often they're not legally or criminally culpable for those actions. The target audience of these campaigns are those who may harm caregivers. Are they going to read the sign? If anything, I think this is adversarial. Okay. You and I don't know, we don't need this sign to know that a hospital is a healing environment. We understand that already. We're not going to engage in these behaviors. But if you have children, you already know if you say, but you don't do, you lose all credibility. So often the hospitals that engage in these campaigns, they lose all credibility with the aggressive patients in their care, and most of all, they lose all credibility with their workforce, who see these signs and think there is going to be consequence that for systemic reasons outside of our control, we can't follow through on. And ultimately, zero means zero. And we, despite our best planning and prevention efforts, we're not going to be able to deliver zero. And it took me a couple years, but I looked at my data. Year over year, the volume and severity of violence was a steady upward trend line. So what we ended up doing is taking all of this messaging down and understanding zero tolerance had failed us despite the best intentions. And it's really failing healthcare here. It's putting us, from my perspective, in a no-win situation. I like the movement towards zero harm from violence. I think we can commit to that. But ultimately, I tell our workforce that Any reported act of violence is going to be investigated individually and thoroughly using state of the science, data-driven best practices. I can deliver that, but zero tolerance has been out of my reach. I think it's out of all of our reach. And ultimately, this overdependence on signs, how effective are signs? How effective is this sign on your commute home from work? So signage really doesn't have an impact on behavior. These signs do not prevent violence. There's a place for signage. It's an opportunity to reflect our expectations and our values. So we certainly have public facing signage here, but we understand it's not going to prevent these risk behaviors and this violence. Code of conduct has been a major focus point nationally. These are not new, but they're really gaining traction on many states across the country, Massachusetts, where I sit, included. Um, However, I'm not saying don't have this. We have one. However, we're not sending this out to all of our 2 million patients. I know other health systems that have done that, and then their call center phones ran off the hook from patient after patient calling in and saying, "What is this? What did I do? Why the hell did you send this to me?" Again, adversarial. To me, having a code of conduct to use with individuals who have had behaviors of concern and we're sitting down and we're having a difficult conversation with them, it's something in writing that reflects our expectations and our values. So there's value there, but this does not prevent any violence. If it was that easy, people like me wouldn't have a job. But I mean it, a lot of people out there think that, oh, the code of conduct, that's what we need to prevent violence. For every complex problem, there's a simple solution that's totally ineffective. And a lot of health systems are realizing that. This is an element of the program. It's not going to make a foundational difference. And ultimately, this is the response of a lot of our community when we pushed out the code of conduct messaging. Here's some alternatives. That on the left side is actually what my workplace violence prevention committee developed here where I sit. So it reflects our expectations and our values. It's not going to prevent any violence. We understand that, but we do think there's importance to having that clearly stated at all of our entry points. And I'm a big fan of sitting down with agreements, patient behavior agreements, safe visitation agreements. This is after behaviors of concern have occurred. We can't go back in time and correct that, but we can be focused forward, sit down, relationship build with that individual, give them the opportunity to express their grievances, let them know what they can expect from us as we move forward and what we require from them relative to their behavior to continue to visit or continue in our care. Very effective. You never use those, though, with somebody in an emergency department who's acutely in crisis. I've seen that happen where the patient in crisis is going to grab the agreement, tear it up, and throw it right back in the caregiver's face. But in an ambulatory environment, office type of visit, I do believe in behavioral agreements, and I've seen them really impact future behavior in a real productive manner. The penalty conundrum is really out there. I've seen so many pushes in many states for legislation, for legal consequences for those that harm caregivers, and I advocate for it too. I absolutely have been lobbying for this for over 20 years. Um, because if it prevents one act of violence or it holds one individual that harms a caregiver accountable, then it's worth all of our time and energy. However, legal consequences don't tend to be a deterrent. And most of all, I think we're overlooking who are the top three patient populations who are assaulting and injuring more caregivers than any other. Who they are geriatric delirium and dementia population. They're not going to be charged with or convicted of a felony, nor should they be. They're not going to be paying a fine for their assaultive behavior. Pediatric behavioral health patients is number two on that list of prevalence. Not going to be charged with or convicted of a felony, nor should they be. They're not going to pay a fine. And third on the list is acutely psychotic adult populations. And you could convince me that they should be legally culpable for their actions, but if you've ever seen an episode of Law and Order, you know that they're not going to be legally culpable because we have generations of legal precedent and case law that they're not going to be criminally responsible for those actions due to their untreated mental illness. So again, I'm all for the legislation because if it does prevent one act of harm or it holds one person accountable, worth it, but it is not going to have this widespread impact on preventing violence that some folks leap to that conclusion. I just don't see that happening, and it has not occurred in a lot of states that are more mature with their legislation. And ultimately, that brings us to considering, is punishment truly a deterrent? In the comp that I often hear is the federal penalties about those who are violent towards aviation and airline workers. And that massive explosion of violence and aggressive behavior at airports and airlines during the pandemic, the first phases of the pandemic, where they saw that explosion. However, they also determined that the mandatory masking seemed to be the root cause of all this aggression. And ultimately, when a lot of these airlines ditched the mask mandates, they saw the rate of violence return to pre-pandemic historical data. So that was the ultimate, eliminating what was the root cause of so much of this violent behavior, and it was effective. And ultimately, even with the penalties in place, we're still seeing a lot of folks lash out violently in on airplanes and in airports for a number of different factors. But it's showing me that the punishments that are well known and well promoted are not necessarily impacting the behavior of individuals. I came across this quote and I loved it. If violent crime is to be curbed, it is only the intended victim who can do it. The felon does not fear the police, and he fears neither judge nor jury. That's often, with my experience, how I view punishments being deterrent. Ultimately, I think we need to look inward, develop our own personal protection plans is the best way to keep ourselves safe. We cannot depend on the justice system. It's out of our control. So that leads me to the true foundations of violence prevention in healthcare. I really think it starts here. It starts with training our workforce, educating our workforce, but then going through the paces of the training for them. If you've ever been involved in a critical incident, you know that Archilochus words rather back in about 630 BC still reign true today. In a real critical incident, we lose half our ability to think and act, but so often the training kicks in. Think about medical emergencies. The same could be said during behavioral emergencies. And what I'm talking about in training is specifically bedside protection, empowering these bedside caregivers to maintain and manage their safety through their stance and how they manage position, posture, and proximity when they're up close. Really, really developing a disengagement mindset. So often, caregivers are bent over a bedside rail, providing an episode of care, and the patient starts striking and grabbing, and everybody jumps in, trying to grab something, effectively controlling nothing, and it's target practice on the caregiver, and serious harm is done. So there is training that condition caregivers to approach the bedside with good balance. Hands and arms come up as organic personal protectors, vital line protected, nose to belly button shaded off on a 45-degree angle. And most importantly, that same patient, as we lean in and we're close, they start grabbing and hitting, we block, and we more importantly move. We disengage from the bedside is our best self-protection measure, and we activate more help. But the more strategic you can be with the delivery of bedside care, particularly that involves restraints and really invasive procedures, taking a team approach, practicing how we do this, particularly when it comes to restraint application and removal, but the practice is where it's at. Our workforce here, where we've seen a drastic reduction of violent events towards our bedside caregivers, I think is part and parcel of our investment in teaching these skills and having our nursing staff practice these skills at the bedside, especially relative to disengaging from the bedside early. And population-specific de-escalation, to me, where it's at. De-escalation is kind of an umbrella term, but the communication strategies and approaches vary considerably based upon the patient population that we're encountering. Here are some of the common populations that our care teams have reported that they struggle for their communication tactics and techniques. So we train them accordingly, and we role play with situational partnered practice to try to develop those skills in a more dynamic manner. And we really see that then apply to the stress of a real situation. And we really emphasize those five universal truths that are borrowed from the verbal judo program, particularly the last one there. All people want a second chance. That's the goal of our de-escalation methods. Focus on their grievance. If we can bring them down to a tension reduction state, create a pathway for them to bounce back and have a second chance. Engineering controls are critically important, and very often the rural hospitals I've had the pleasure of going to have started investing more and more in engineering controls to protect their caregivers from vulnerabilities. You can see on the slide, some of the areas for investment that we really advocate. IHSS has a great security design guidelines for healthcare facilities on the third edition. The fourth edition will come out this year. I strongly encourage you to invest in that tool if you haven't done so already, particularly if you're having renovation or new construction. Go to the guidelines. I do that. I've been doing this for 25 years. I never want to overlook something when I have that guideline really steer us when we have renovation come up and those opportunities to add more access control systems and surveillance cameras, etc. Very often there's that focus on panic and duress alarms. And it's really important. I'm not minimizing the importance of activating emergency responders. It's critically important, but healthcare's really invested heavily on it, and they're still seeing that drastic increase in violence, volume, and severity. Because let's face it, human nature, very often the panic button is pushed after the harm's already done. And often we overlook empowering the workforce with options of push the button, then what? What about that gap of time before the help gets there? What can you do to keep yourself safe? Most importantly of all, disengage, get away from the threat. But that is not intuitive. That needs to be built up through training. But yes, have, emergency response activation technology. But what about that gap of time before the help gets there? Everything being integrated. And of course, what can we do in the direct environment of care, be it safe rooms, etc., to really protect our patients from self-injury and also our colleagues from harm, kind of a dual aim there. And also administrative controls. These are our policies, our procedures, our practices here. There's a lot of exciting stuff going there. A lot of this stuff is really resource dependent. I don't have my own K9 program here yet. It's my dream. I know Hartford Healthcare here in New England has a great program. Body-worn cameras are going, but again, these are major expenses that often critical access hospitals, rural healthcare environments can invest in. But you absolutely can build up a robust threat assessment and threat management team. Every hospital can do that. It might be what I've learned in rural healthcare is the SFP, the same five people that serve on every committee and really lead the organization, but getting together and being that a threat assessment and threat management team. IHSS has launched some great education on how to do that. That's to try to protect us against targeted violence. Example, patient's family member, there's a loss of life and they're perseverating on one of your providers that they're trying to scapegoat and blame for the death of their loved one. That really requires a response from that organization to assess that threat, to manage that ongoing threat that will often last for extended periods of time. We can all try to focus on lateral violence, incivility, and bullying within our walls. That's the type of violence we have the most control over is our workers, that type 3 violence. And also how we establish our reporting culture and we try to collect data on where is violence occurring in our facility, what time of day, who's being harmed, who is doing the harming. That helps us build up some intelligence and hopefully proactive interventions. I'm a big fan of research and evidence-based clinical violence assessment tools in the electronic medical record. We use the BroSet Violence Checklist. In Epic will generate alerts of past risk behavior, give us the opportunity to standardize plans of care across the spectrum of care. Behavioral emergency response teams are growing in prevalence in organizations, including rural health. So we activate those key team members to respond to an area we have a violent or potentially violent patient, to then advise the team and consult with everybody about how we move forward and try to protect everyone. And I mentioned a lot earlier about behavioral agreements in really difficult conversations, trying to create that pathway towards a second chance. And professionalizing public safety and security. I know the majority of rural hospitals, critical access hospitals, may not even have uniformed security personnel. I think that that may change over time, but it is a heavy investment in people and bringing them in and the training that they would require and the caliber of people that you need. But organizations that do have strong public safety and security personnel always see a reduction in violence when they've stood up that type of program, and they have those go-to people who can be proactive when engaging people that are presenting risk behaviors, and particularly be the front line when that violent, aggressive patient does need to be controlled and restrained. Um, Ultimately, in the time we've spent together here, I hope that these have been the contributions that I've been able to bring to the hour. Caregiving and violence prevention is the ultimate team sport for sure, and ultimately, it's the opportunity for those who are leading programs and departments and organizations, opportunity us to be really intentional on how we lead. My contact information is below there. I'm an email away if you have any specific questions you'd want to run by me. But the couple minutes we have left together, I'd like to invite Cassidy back if there's been any questions in the chat.
Thank you, Brendan. Let's open up the chat and take a look. I don't see any offhand, but you do have a couple of moments left, and we want to make sure that we get any questions you have answered. So please feel free to unmute and just jump in, interrupt me, or drop your question into the chat, and we will make sure we address it. And while we're waiting for you to do that, I'm going to drop a couple of links in the chat for you. If you are interested in individual workplace violence education or support, please reach out to the Rural Engagement Program. This first hyperlink here is our email address, and you can use that to email us and just let us know that you're interested, and we'll reach back out. Mr. Riley has done some really amazing work with some of our hospitals, and you have shared some absolutely valuable insights to addressing workplace violence in healthcare settings. And I know it would be beneficial to so many of our hospitals here in Texas. I want to monitor the chat again. I don't see anything. Okay. I've also dropped the second link, which is our request technical assistance form. And then just our website is the third link. Thanks for that comment, Nancy. She says excellent information. And before, I'm going to go ahead and launch this poll before we lose too many people trying to get back from their lunch break. So if you have a moment to complete the poll before you drop off the call, we would appreciate that. Let me go back, Brendan, to the chat. And I don't see any raised hands. Thank you for that comment. Very informative. Thank you. Okay, Brendan, I don't know if we're going to get any questions today, but we are so fortunate that you were able to present for us today. And hopefully we will hear from some of our hospitals that have been on the call today, so that they can get some more information.
Okay, my pleasure. Thanks so much for inviting me. Take care, everyone.
Absolutely. Thanks, everyone.